I'd like to welcome everybody to today's webinar, Hospital Reporting Final Rules, what you need to know for 2019. Hang with us. I have 9:57 on the official webinar clock. We will get started at 10:02, 10:03 to give everybody a chance to log in. Take this time to download the handouts, and if you have a question, go ahead and put that question in now. We're going to answer all the questions at the end. So hang with us. We'll get started soon. I have 10 o'clock. We are going to wait just a minute or two more. We're expecting quite a few more folks to be logging in. And it's a Monday morning. We all need our coffee. Hang with us. We'll start in about 2 minutes. I'd like to welcome everybody to today's webinar, Hospital Reporting Final Rules, what you need to know for 2019. Just a topic you want to kick off your week, starting on a Monday. So get your coffee, and we're going to tear through these slides. Now, if you do have a question at any time, as always, you enter into the questions feature of the GoToWebinar, and we will answer every single question at the end. Also, the handouts are available. The slides for today are available through the handouts feature. but we will also record this webinar, including the Q&A. They will be available on the ClinISync YouTube channel next couple days or so. Now, today's rule, we've got kind of a sprinkling. This is a hospital-focused webinar. There are a few little tidbits that we pulled out from the physician fee schedule, but it's primarily the hospital outpatient rule, the hospital inpatient rule, the physician rule. We've got kind of a sprinkling of different rules that they jam together for that final rule. Most of that rule will be effective on January 2019, with the exception of some quality measures. If you are participating in an APM, that won't be final until 2020. If you're in an ACO, you know, there's a big ACO rule coming. Well, they slid a little bit of it into the physician final rule, and but they did extend the deadline for ACOs out to June 30th. And then there's some E&M coding and payment stuff we're going to talk about that actually doesn't take effect until 2021.
And before Scott flips off of the rules, just kind of a higher level of what's going on with CMS. We are expecting, besides the risk-bearing rule for the ACOs to be released, the other two that are in process is what they're calling the information blocking rule. This is really important to the hospitals when that does come out, because it will have impact on both your release of information to the portal so that it's available to the patients for other providers, so the release of information to providers, but also the release of information to the patients. And so when those rules come out, it's going to be a high priority item, especially given the weighting that CMS is giving to patient access for data. It's one of their top priorities for 2019. The other rule that is not final but supposedly is out there is the what we call TEFCA rule, which is the proposal for interoperability across the country. And the reason this will be important to hospitals, and we're waiting to see how this is developed, is that they were trying to drive a combination of regulations and contracting under conditions of participation to get to the question of mandating interoperability. Obviously, there are a lot of issues there. I can't say how that's going to look, but it's one that, again, a heads up, when it comes out, we will be doing webinars on these areas because they're going to be important to all the providers.
So with that, we are going to roll right into some changes with the hospital reimbursement rates. And I'm going to turn it over to Cathy.
Thank you, Scott. You can tell it's Monday.
Oh,
they slipped a few slides in on me. Anyway, and of course, and Scott, why is it? There we go.
All right.
Okay. This is just a recap. As most of you know, a lot of the hospital financial picture is painted every year in the hospital IPPS rule. There are some aspects of your potential bonuses and penalties that come into play in the outpatient rule, and for the CAHs, you are driven by a strictly separate line of reimbursement. But what I wanted to say to you is, please note all the various places where you can receive penalties as well as the bonus for value-based purchasing. So it's really important that people understand that this is not like meaningful use was, where if you met your measures and you met your benchmarks, you were going to get a bonus. That is not how hospital reimbursement works. And so you need to be aware that some of the same measures that you work on under one program are going to either give you a bonus or a penalty in another. So you have the readmissions program. It can be up to a -3%, depending on your value, and hospital acquired conditions is up to a -1%. The value-based purchasing, I just want to mention that because those figures were released last week, less than a week ago, by CMS for all the hospitals across the country who get reimbursed through IPPS.
And that information includes, within that list, you can see the percentage increase or decrease that each organization is going to be subject to.
Right, and although technically it can be a 3% swing in either direction, so a 6% overall swing, the reality is we looked through it. We did a quick, eyeball of the figures as they came out. And the margin has really narrowed tremendously amongst the hospitals. Excuse me.
Yeah, it's usually less than 1%. I would say there's either way it's probably a full percentage point.
It's plus or minus 1%, and even then I think it's tighter than that.
Yeah.
Okay, the thing to remember on this slide, and you can't stress enough, we try to let the financial people know about this because I think they tend to forget that once we're out of meaningful use, you can still be receiving fairly significant penalties if you're not meeting what we used to call meaningful use, ACI, and now promoting interoperability. As you can see, as you look down this slide, it's fourth from the bottom. Promoting interoperability, if you don't file an exception, if you need a hardship, and you will be penalized more than 2 percentage points in your hospital inpatient reimbursement for the year. So very important that you keep in mind that programs, even though the type of money attached to it may change, the penalties frequently do not disappear because they are mandated legislatively. And so that's the biggest thing to keep in mind here. Obviously, the IQR program and the hospital outpatient quality program have their own set of penalties if you are not participating. As far as weighting, and this is something that was in the inpatient rule, but just to rehash for folks, the value-based purchasing is composed of the 4 areas: clinical care, which is mortality figures, your safety measures, a lot of hospital-acquired conditions here, your cost, and your patient satisfaction are the 4 categories that feed into the value-based purchasing for a hospital's overall, what we call their potential bonus for the year, potential bonus or penalty. And the amount that this is, each area plays this year, because this can slide back and forth each year, is each one is weighted at 25%. So they kept that 25% across the board for hospital reimbursement for value-based purchasing. On the hospital readmissions reduction program, here are the areas that are tracked for readmissions, and that's something to keep in mind is on readmissions, it is not all readmissions. You have to look by condition as to, I mean, you obviously want to look at all your readmissions because there's and we'll look at that measure later. There is a general condition readmission, but this is for the hospital readmissions reduction program. So your penalties for hospital readmission include these 6 areas, 5 of which are acute and 1 is which is elective. Again, the weighting of the measures, you notice how everything comes back around again. It just kind of drives you crazy that CMS, when they talk about having meaningful measures and cutting back reporting and stuff, it's really that they are just reordering the same information and using it a little bit differently. But the one thing that we want to make sure everyone is aware of is the hospital star ratings are out there, as are the physician and as are the long-term post-acute care. So, and this is something, because this is the public-facing information that hospitals are going to live with. And the hospitals of all the hospital compare, physician compare, and long-term care compare websites The Hospital Compare has way more information than any other group. And so you want to be aware of what is being published there and make sure that you review that and look if during the time when you can appeal it if you don't feel it is correct. The 4 categories that go into the value-based purchasing are still 88% of your overall 5-star rating for the hospital. And then you have timeliness of care, effectiveness of care, and efficient use of medical imaging as your last 12%. So they are not nearly as heavily weighted as your 4 categories for value-based purchasing.
And we are in the Physician Compare preview period right now. You access that data through the QPP portal. I strongly recommend you check it because this is the first year that MIPS data will be included. And we've already seen a few problems with some of our folks. If you have any questions, give me a call. We'll jump on it together and go through everything.
Okay, and then the last general comment I have about hospital reimbursement, mainly because we get a lot of questions about this when it came out, and this is under the outpatient rule. There is a ton of information about the 340B drug pricing program and the impact of all the things that CMS did with it. I would highly recommend, if you are a hospital, that you look at AHA's analysis of that. I actually had heard them last week on that, or contact OHA. But the number one thing that we get asked about on the drug program, downside pricing, because it's decreased by 22.5%. So it's really important you understand the impact on your hospital if you had drugs that were being purchased under that program. If you are a CAH, you are not affected by this cutback at all. And the other thing that we get asked a lot is if you were purchasing your vaccines under the 340B program, the vaccines are not affected by this cutback. So very important that you recognize that when you're looking at your reimbursement.
So now we're going to talk about the hospital quality reporting, both inpatient and outpatient side. Now CMS did release a lot of news releases that they were, cutting back the number of measures. They were cleaning up the data that was being submitted, and that is true. Now the reality of this is that it was overall not really a reduction in the quality measures that you're going to be submitting, but they did reduce the overlap. So if you were doing the different programs, value-based purchasing and IQR, they've tried to eliminate as much of the overlap as possible. We're going to first look at the hospital outpatient quality reporting program. In 2018 and 2019, so for this year and next, you will see that the leftmost column are all of the measures that have been removed, OP27, OP5, a lot of measures removed. It looks like we have about, 7, 8 measures there. In the middle, these are the measures that remain for the outpatient program measure set that was finalized for 2019.
And please note on the removed measures that flu vaccine, every year about this time you hear a lot of pushback on the hospital employees and the flu vaccine. Although this measure is being removed, it's only being removed from the outpatient program. It is still reportable under the inpatient program. So just keep that in mind.
And then finally, in the rightmost column, these are the required web-based measures for your 2019 reporting year. You will get a copy again. This is included in the slide deck, so we're not going to go into each of the individual measures. Now we're going to look back at the IQR, your inpatient side reporting. CMS is cutting back the ECQMs, chart abstracted measures, and claims measures. Way out in 2020, the 7 ECQMs that will be removed are right here on this slide. Now, once these go away, if you are part of a CAH, some of the measures you'll see here, we see ED1 used a lot in the CAHs, and we're still kind of waiting to see where CMS goes with the ECQMs for the CAH, because there's not a lot there. Also, CMS remains silent on if they will increase the number of quality measures that will be reported electronically or the time time for these. Will it be 2 quarters, 3 quarters, 4 quarters? That remains to be seen, but we expect to see something in the next rulemaking period.
Yeah, we still think that the rules, the 2020 rules that will be out for the hospitals probably in April, will address the CAH situation specifically in the rural hospital, because these are the areas that CMS has received the biggest pushback, because the groups do not fit into the need buckets that CMS has for the larger hospitals for some of their quality reporting initiatives.
There are a few chart abstracted measures that are going away for the 2019 reporting year: the flu immunization, the BTE6, ED1, those go away for 2019.
As chart abstracted.
As chart abstracted measures. They are still parts of other programs. ED2 will be removed in 2020, but it's hanging around as an ECQM. It just will no longer be a chart abstracted measure. And interesting enough, this sepsis 1 is the only validated measure that's left in the IQR program. So now there are some patient safety measures that are going away. PSI 90, we see this one used a lot, but this will be going away as a patient safety measure starting out in 2020. Also, there are some other ones that are being removed in 2020, your CDI, your MRSA, a few others listed there in the middle of the screen. The mortality, AMI, and a few others will be going away in 2018. You'll see here in the last bullet, so this reporting year, but they're keeping around stroke, which will be stroke stays, and hip and knee go away in 2021. And finally, some episode-based measures are going to be removed as well, starting in 2018, so you'll no longer see your cellulitis, the GI hemorrhage, UTI, and a few others.
But please note, the reason these are going away is because CMS is starting another big push towards episode-based measures, and we're going to talk about this towards the end because it also affects your Medicaid situation. But they're also looking at bundled payments in a big way. They have a pilot out around this, the bundled payment model, but just recognize the fact that it's being removed as a reporting measure this past year in 2018 does not mean that it's going away. It's just been restructured.
Right. There's going to be different episodes, different bundles put together, a lot of changes on the horizon for reporting. So now I'm going to turn it back over to Cathy, our ACO guru, that's going to go through some changes that were noted in some of the rules.
Yeah, some of you probably heard us last week on the APM, but I think it's really important that people, whoops, I don't know why this is so touchy, but it's Monday. The computer's touchy too, Scott. It's your computer, so it's your fault.
It might be.
But anyway, okay. But I feel that there's so many ACO participants in the state that it's worth mentioning this because it's part of your overall quality strategy as an organization if you're doing any type of ACO reporting, whether it's risk-bearing, non-risk-bearing Medicare shared savings, and as we've started to hear, there are a ton more of the private commercial payers, but that's to be continued later this year. On the ACO measures, it's kind of an interesting cross-section. Those of you who have been doing ACOs for a while know that I think at its high point there were at least 33 or 34 measures that you had to report on. And now CMS is trying to peel that back. And if you do not have sites who are involved in CPC+, but most of you probably do, high number in Ohio, CPC+ is down to reporting just 2 outcome measures. They're reporting A1Cs out of control and blood pressure less than controlled blood pressure, less than 140/90. And I don't know over the next year or two if the ACO quality metrics are going to continue to shrink. And that may be something we'll look at when that rule becomes final, or the next ACO rule, the risk-bearing rule, if there be any further discussion about quality in that. But they're removing meaningful use percents out of your quality metrics. You still need it as a contracting matter for ACOs. MedRec post-discharge I personally believe this is going away because under the new promoting interoperability regs, you have that query and retrieve measure, but as part of that, you are required to do reconciliation in order to get credit. So I think this represents CMS trying not to duplicate some of the approaches.
And under the MIPS program, the MedRec post-discharge is what they consider an extremely topped-out measure.
Yeah,
Both this one's actually extremely topped out, and the regular MedRec is considered just a regular top-down measure. So we'll see both of those going away soon.
Yeah, and pneumonia vaccines going away. We're waiting to see if maybe next year it's replaced with the new shingles vaccine. But for right now, for 2019, it is not going to be reportable. BMI is not reportable. Boy, that's been in since the beginning of meaningful use.
Very early
note the eye exam for diabetes is being removed, but you are not having the A1C removed. I know this was a combined quality measure for ACO. What they're doing is splitting it, removing the eye exam, keeping the A1C. Use of aspirin for IBD, that's a very common one that we see used a lot, but as Scott has so often pointed out, this is a topped-out measure, and so I think that's why it's being removed from ACO also. The next group is related to readmissions, and we're going to talk about that in just a minute. And the use of imaging, this was funny because there was a split in the experts who were commenting on these rules. They have that MedCap group, which is a physician, it's like a HIT group who gives CMS advice on clinical matters. And they did not want this removed. They were like, no, we still need to be tracking the overuse of imaging. But the reason CMS removed it is because it's been removed in the MIPS program and in other places, and they were trying to be consistent with the reporting. So again, it does show up elsewhere, because if you think back on those slides that we looked at under the 5-star rating, use of imaging is 4% of your total there. So again, it's just be aware that it may disappear in one place, but not totally disappear elsewhere.
And that measure is also gone from QPP as well. So
yeah, that's why they said they were going to do away with it, because the physicians weren't having to report on it. The CAPS, 2 new measures. I think you're familiar with it: office staff and care coordination. Care coordination, again, is such a high priority item for CMS. You see it in every single avenue now. They expect to see care coordination. They expect to see it across the continuum, and we're going to look at that in 1 second. And the risk of falls is added, and we're going to look at the change there because there was a change. Here's what the final list for, whoops, I'm sorry, this computer is like, has a mind of its own. Poltergeist. Here's what the final list looks like. You're going to have your CAPS surveys. You're going to have the readmissions, which we're going to talk about in a second, preventive health, and then your high-risk measures. So it's broken into the 4 categories, still each weighted at 25%. But on the readmission, let's just look at that category for a second. You've got all condition readmissions, so that's your overall, no matter what the cause. Then you've got the admissions for patients with multiple chronic conditions.
So that's really focusing on your high-risk patients.
Yeah, and we're going to look at that one. And ambulatory sensitive conditions. Those are the ones that CMS is like, if you had been really monitoring this patient and doing care coordination on them, of course you're always going to have some of them in the hospital, but you should not have to send every one of them or a high percentage of them to the emergency room if they're being cared for in the outpatient setting. And then the risk of falls, we're going to look at that again. Again, this is the high at-risk population.
I don't know why that keeps doing that.
Okay. For the unplanned admissions for multiple chronic conditions, this is the list specifically that CMS is looking at for the patients who are tracked with more than one condition. It's diabetes, heart failure, AMI, dementia, AFib, chronic kidney, COPD, and asthma, depression, and stroke. So it's very similar if you've worked in the care coordination and care management area for the past 5 years. You will recognize this is very similar to what CMS was putting forth under their chronic care management program. So basically, it's a list of patients that is going to be at your higher end of your risk stratification, because they are almost always going to have 2 or more chronic conditions. And this is actually why CMS removed the tracking for diabetes as a readmission measure, because they said 85% of the diabetics fall into this category, multiple chronic conditions. The long-term care, I'm only pointing this out. This is not a measure. CMS has not figured out what they're doing, but they had a big discussion about it. So again, we're telling you because it is coming back around next year. And what it is the issue is, that CMS is grappling with hospital discharges is if the patient goes to a SNF or post-acute care, the measure up until this point in time had been tracking for the past year or two back to patients who then get readmitted to the hospital within 30 days. Well, CMS kind of figured, as they started looking at the flow of patients who end up back in the emergency room, that not every patient goes to a SNF and then is released to another facility or released to home, and they're losing the ability to track that some of the patients were actually going home and then coming back to the emergency room. And so they're looking at possibly doing a readmission measure that calculates the patient who does a step down from the hospital and then goes somewhere else but ends up being readmitted to the hospital. So it's more complex analysis, but what CMS is saying basically to the hospitals, make sure that you are coordinating that patient's care so that they are not ending up back in the emergency room and back in the hospital being admitted. They will look at this again next year. It is not final. I'm just giving you a heads up on it. Okay. Oops, am I going the wrong way? Yeah, we are. Okay. All right. Risk of falls, just to point out to folks on risk of falls that it's not just the assessment anymore. Like so many of the other assessment measures, there's now a separate second part to calculating that measure. And the risk of falls requires you to do the assessment, but to also do a care plan that includes balance of strength training, referral to an exercise program, or referral to physical therapy as part of that. It does not all have to be done during the first visit, but at some point in the 12 months, there should be, if the assessment shows a potential risk of falls, there needs to be this referral for further training and weight training and conditioning for the patient.
So as I apologize, we're getting some auto advances on our slides here. So CMS is really focused in on 3 priorities for the 2019 calendar year and going forward. You know, they're focusing in on promoting interoperability, or that transition of data between providers and from provider to patient. A lot of work around restructuring the payments, doing away with some of the payments we've seen. Cathy's going to go into that here in a little bit more. And then, as always, CMS has always had a real focus on the ability of a patient to gain access to their medical records, and they're really expanding that with APIs and the information that you have to make available in the portal. And
big time.
And we're going to see more of this in the information blocking rule.
Yeah, we'll talk about this as we get back into the technical guidelines for 2019, because as these final rules came out, we were not overplaying that. You know, you kind of, as the promoting interoperability as a new program's gotten there, it's like, what type of emphasis is there? But there was high emphasis on all these final rules about patient access. Okay, so under Medicare payments, what I would say is the biggest help I can give you on the Medicare payments, because this was huge, again, across all the rules. It was top priority for CMS.
And actually, this very first one, there were so many articles written in the trade magazines and large and small organizations raising the red flags and, hey, this is going to kill us. This is going to shut us down.
Yeah, and what I would say, the best thing you can do over the next 2 years, and we'll tell you in each slide what goes in next year, what goes in 2020, what goes in 2021. You need to sit down with your hospital. I don't know if it's your HIM department, your book coding and billing, but everyone is going to have to be familiar with these changes, because this is a radical change in how CMS is both accepting, billing, and requiring documentation, especially for physician practices. So as a hospital organization, you want to make sure that you understand these changes. Make sure that your coders and billers are attending classes over the next 6 to 8 months, so you can start developing a strategy about all these changes in billing that you're going to have to make sure are done, so that you are getting adequate reimbursement in your outpatient and ambulatory setting. The first of these has to do with the billing of facility fees for practices that are hospital owned. And as you know, that came in 4 or 5 years ago. Big move for a lot of hospital systems to have physician ambulatory settings bill an add-on fee for facility fee for their hospital outpatient visits. And the trouble was, CMS has talked about this now for a number of years, but they actually documented it all. They must have spent 15 pages in the rules documenting this, that it was costing CMS 60% more for the same physician office visit if it is billed through the hospital with the facility fee on it than it does if it's billed by an independent physician office. Now, we won't get into the issues that were raised, because there were quite a few of it raised about for the rural hospitals, and the CHs aren't affected by this, but especially for the rural hospitals, and the fact that they were using some of this funding to support other initiatives by CMS, whether it was their quality reporting, or whether it was care management. And so to remove the facility fee is a real burden for a lot of hospitals. We had 8 or 10 hospitals in Ohio in the top 200 hospitals that were affected by this proposal to cut back on facility fee billing. So we know what we're talking about here. And what CMS is doing is they're saying, okay, we recognize that there's going to be a hardship for a lot of hospitals, so we are going to cut back on a 2-step basis. Half of the facility fee will not be paid in 2019, and by 2020, we're not going to pay any. That's a proposal. I mean, that is not proposal, it's final in these rules right now. This does not include your ED, facility fees, or critical care services. But what I would say is, again, CMS carved out the possibility of an exemption for rural hospitals in this. They said they are going to look at the impact on the rural hospital in the 2020 rules. So in about 4 or 5 months, when those next round of rules come out, we will see if CMS backs off of the billing for facility fees and allows, say, the rural hospitals to bill half of it. That's one proposal. So
yeah, the likelihood of CMS coming back and telling those rural hospitals that they're going to reinstate the half they took away, I think that's pretty slim to none.
Yeah,
it's just going to be you're going to keep the remaining half.
Yeah,
we think. Again, this is our guess.
Yeah, this is CMS talking about, quote, leveling the playing field. Just the removal of half of it is worth almost $400 million to CMS in 2019. So they clearly aren't going to just back away from it. So that's probably one of the most significant changes that affect both the hospitals and physicians. This one we'll talk about, but honestly, this is one of the ones you're going to want to make sure that you have a coding expert to work with you on this. The first part of the rule, this was in the physician fee schedule rule, and CMS is taking the 5 levels of patient visit, so 1 through 5, CPT code, going from the simplest case to the most complex, and saying that we are not going to continue to bill 5 levels. We're going to pay for 5 levels. We're going to pay for the simple one, level 1, CPT code level 1, and CPT code level 5, where the most complex patients will continue to be separate billings and separate payments. The 2, 3, and 4 are going to be collapsed into one code. And this is where you want to make sure you understand, as CMS fleshes this out over the next year, that you understand all the coding, because there's some tricky things that they put into that rule. This date is not effective until 2021, so you do have time to get trained on these new codes. The other thing that you want to be aware of, because this does go into effect in 2019, is documentation of a history and physical. CMS talked a lot about this, and I do think it was well worth their time to look at this, and that is that the documentation that was set up historically, that they've been operating under for 30 or 40 years, was all based on paper charts. And so there were things that were prohibited under your documentation because it was paper and they didn't want to see you just copy stuff. But the reality is, in the electronic health record world, all of this is right there in the in your patient's chart. And so there's no reason why you have to reproduce the information each time. And so you want to make sure that the physician checks it, but you don't have to go through your whole analysis every time the patient is seen. The other thing that's a big change, and this is going to come in 2021 with the change in how it's billing, is the documentation of those physician office visits. And there's going to be 3 different ways, one of them being time-based, one being the historic way of documenting, and one being medical decision-making. So again, you want to figure out how your physicians are going to be documenting a patient visit. And important thing for those of you who have home health programs, effective this January, home visits will not need to document medical necessity for payment. Here, the next 2 slides are really CMS's proposal as to how they're going to bill, or how they're going to pay for physician office visits. But I do want to point out that even though it appears that some of the payments have been cut back, CMS, again, is going to put G-codes on everything. So there's a complexity G-code for primary care and for specialty, and additional codes for extended office visits. And just in case you're thinking that this is going to be an odd code, something that's not used often, I read through this whole quote when you go to work with your people on the change in billing, but just note that first bullet. This is straight out of the regs. We would expect that most practitioners enrolled in such specialties as family medicine, internal medicine, peds, and geriatrics would be billing the primary care visit complexity add-on code with every office outpatient E&M visit. So again, they're very important that you get expert guidance on this, because it seems like they're saying that you would use the G-code for virtually every office visit.
Right, which doesn't make sense.
Yeah,
but...
so just be aware of that. And then I'm going to turn this over to Scott.
CMS has really worked to expand telehealth. And the telehealth, there are some limitations around what you can do. You got to be in a rural area. It can get a little difficult, but CMS did carve out what they're calling a virtual check-in. I also kind of think of this as chronic care management light, because it doesn't have all of the requirements that chronic care management has with the 20 minutes rule or whatever. This virtual check-in is intended for those 5 to 10 minute provider to patient interactions. This can be through the portal, this can be a phone call, this can be what you kind of were doing in the past for free if you get a call or you're responding to a portal message, and it's G2012, Brief Communication and Technology Service. This is listed as an RVU 0.25. Our understanding is it has a $14 reimbursement rate, but the important part to remember is this is subject to copay, which could limit its use, and we're going to have to see how this kind of plays out. It does require at least verbal communication or authorization with the patient that they know that this is subject to a copay. There's also some codes that allow an interprofessional consultation without a face-to-face visit that were added. And again, this is one that I want to kind of see how this plays out. This is intended for the primary care to reach out to cardiology or another specialty to get some information or some recommendations around what to do with the patient. There's also this GRAS1 code, and this is a remote evaluation of pre-recorded patient information. Think of this as with dermatology. If a patient takes like a high-res picture of a mole and sends it, says, hey, what do you think, doc? You can now charge for this as well. Now we're going to switch and talk about promoting interoperability, or we used to call this meaningful use, even though we're not allowed to use that word anymore. But back in the early days of meaningful use, you'll remember that the hospital and the physicians had the exact same set of measures. And then at some point, things kind of broke away. There was some variance. Well, now CMS has really came back and said, you know what? Our focus is going to be all around sharing of information, whether that's with other providers of care or with the patients. And we're going to do away with some of the other less meaningful measures, and we're going to have the same measures across all programs. So now we have these 5 big, we'll call them buckets. Except Medicaid. Medicaid's doing their own thing. We've got to kind of wait to see what Ohio Medicaid does there, but if we see some changes there, we'll make sure everyone knows about it. But our 5 buckets, privacy and security, never going away. There's some interesting stuff happening with ERX, which we'll get into here in a little bit. We've got 2 HIE measures now, patient access, which was portal, and then, of course, we're always going to have our public health reporting. So what we see now on this screen are the objectives and the measures within those objectives. These measures and objectives are the same for both the hospital program and the QPP or MIPS program. On the hospital side, you only need to exceed 50 points for successful reporting. Under QPP, this is what was your ACI category. But at any rate, let's look a little bit at the measures. Your privacy and security, you don't get any points for it, but you have to do it. It's a required measure. ERX, the language around ERX was so confusing. There were sections where they talked about the importance of electronic prescribing of controlled substance. They kind of make it look like it was almost required, but then when you get to the base, the numerator, denominator, and exclusion language, it made it look like it wasn't. We reached out to CMS. Cathy put together a nice email. We submitted it to the help desk, and here's the response from CMS. What they say is ERX, your standard ERX is really all that's required from a base. But if you do not do EPCS, then you have no means of receiving the 5 bonus points for the PDNP or this verified opioid agreement, which is another 5 points, which the technology is just not there for this one anyway.
Yeah, but keep in mind, this was an interesting problem for Ohio providers because the Ohio controlled substances prescribers were already required to be doing an ORS check. And so we thought that they were going to get an automatic 5 bonus points for doing that. But that's not how it works.
Right.
If you can report your general e-prescribing the way you've always done it in 2019 if you do not have EPCS implemented yet. But if you do not do EPCS, you cannot claim that ORS bonus. So just keep that in mind. Your strategy for timeline should be, what are you trying to achieve here? CMS, again, opiate is a huge overarching issue in all the regulations, and this is their way of promoting controls on opiates in the everyday prescribing area.
So for that ERX measure, if you do EPCS, you include opioids and controlled substances in your numerator and denominator. Again, you don't have to. The PDMP check or the ORS check, this is not a yes-no. This is a numerator-denominator measure, which could make it difficult for those folks who do not have an integrated PDMP solution. So if you're logging into the ORS page, this may be one you have to manually calculate. CMS has already said manual calculation is acceptable and are going to release some guidelines soon on the documentation that you'd have to obtain.
We're reaching out to the Board of Pharmacy to see if we can get more information on how reports can be generated through ORS. And if we can get them engaged for a webinar, we certainly will do that. We think it would be helpful for everybody.
Right, and your denominator for this measure would be all the opioids, or I'm sorry, all the opioids that you have prescribed. The numerator is how many did you check for the ORS database. It should be 100% in Ohio, but we have to have proof. For your health information exchange, this first measure, support electronic referral loops by sending information. You've already been doing this. This is the measure we've had for the past few years about sending a message via direct. The second one, the support electronic referral loops by receiving and incorporating health information. This is really two measures that were originally part of stage 3 that have been combined. What this says is if you have a new patient presents, you either have to receive a CCDA via direct, or you query an outside source, such as an HIE, such as CliniSync. If you find no information, then your patient still falls into the numerator for that measure because you looked. But if there is information, or you're in the HIE, or you have received a direct message, you then must reconcile that information for that patient to fall into the numerator. When we say reconcile, remember clinical information reconciliation, it's no longer meds, it's med, allergies, problems. And problem list is a problem because a lot of folks, your problem list sometimes get a little messy. Maybe you've not reconciled problems off that list or closed out the problem. Folks are struggling with this one.
Yeah, generally that's called the query and retrieve measure, but you have to think of it as query, retrieve, and reconcile is really what it is.
And together, those are 20 points. Now, the second measure, there is some exclusionary language for this year, more or less if your vendor couldn't do it. And if you do take the exclusion, then your direct message gets reweighted to 40 points. Your third objective is patient portal. Are you sharing information with the portal? And are you making it available via an API? You'll notice VDT goes away. Secure messaging on the physician side goes away. It's just make the information available and address the issue of an API, which is an issue. Yeah,
it's the phone app is basically what CMS is saying. And they are so hot on using these phone apps that even though there were tons of comments related to the security of the phone apps, CMS not only kept them in all the rules, they basically kind of promoted them even more. So I still believe that in the next 6 months we'll see, and maybe it'll be in the information blocking rules,
could be,
is that we'll see more guidance on the security side of this. But for right now, you still are going to need a strategy for 2019 around the development of a phone, and not the development, but the access to phone app integration for your system.
And just keep in mind that as an organization, if a patient wants to connect to a phone app that you deem as being unsafe, unsecure, you do not have to support it. You've got to find something, support something, talk to your vendor, go with the vendor recommended app. Most of them have something. For your public health reporting measures, we saw some changes here between the proposed rule and the final rule. The good news here is you only have to do 2. If you're doing immunization and syndromic, you're covered. If you're doing ELR and anything else, you're covered. 2 measures, that's a good one. Again, hospitals, you only got to get 50 points to exceed to be deemed as a successful reporter. Right now, there's no difference between 51 points and 91 points. They're, under the QPP program, they give you a little bonus if you're a high performance or you're a high performer. We haven't seen that here yet. I'm going to turn it over to Cathy. She's going to tell you about some craziness and chaos and payment models. And guys, this is heavy. It's hard to understand, so listen close.
Yeah, we're just going to keep this brief because there's a lot of questions still around these new payment models. Note that if you're in Medicare Shared Savings and you're supposed to end on December 31st of 2018, you have the option to continue to report until June 30th of 2019 to allow CMS to get those new regs out that they haven't finalized. That is going to require everyone to be risk-bearing. If you're in a shared savings that does not terminate this year and runs either through 2019 or the end of 2020, you can continue on in that model under this proposal, but you would be cut back to 25% of the shared savings rather than the current 50%. This, again, was a controversial proposal, and so it has not been finalized. We'll see if this occurs. As far as the actual overall structure for these new ACOs, you either have your basic model, which are people who have never done shared savings, have never been involved in an alternative payment model. They would not bear risk until, I think it's year 3. So they will continue to glide on at a lower risk level and then kind of increase the risk over the 5-year, because contracts will be 5 years now rather than 3. The enhanced model will be anyone who's been involved in shared savings before, so that they are being compared to their peers, and they will automatically assume risk under their contract from year 1 of the contract. And that is what is controversial because of the amount of risk CMS is asking you to bear. The all-payer advanced APM that's supposed to be coming in 2019 was very interesting to watch develop. We thought it was going to be, hey, anybody that you're involved with, you can add up all those patients and you can meet your minimum eligibility and get all your providers 5%. That is not what the all-payer model is. You have to be meeting your Medicare minimum patient load before you can even begin to add patients from other payers as part of this risk, or as part of this model.
So really what this means is you have to be in a Medicare APM before you pile on this all-payer option. Correct. To meet your QP status.
Right, and it's the advanced APMs. This is not shared savings. This is advanced APMs. So what the game here is that CMS is giving you, as they increase the requirements for ACO participation, because it goes from 25% to 50% to 75% of all your Medicare patients, Medicare fee-for-service patients, that they give you a way of adding patients to your base so more of your providers can be QPs and can earn the 5% each year. So just keep that in mind. It's more of a sleight of hand to develop your eligibility than it is, at least at this point, a true shared saving or APM. And the other thing to say about this on the all-payer side is there are pilots out there. They're called MAQI, M-A-Q-I, for Medicare Advantage programs, are doing pilots around true shared savings. And so I think that we'll start seeing some more results on that, probably maybe at the end of 2019, and better understand how CMS is going to refine the all-payer model. Just note, because every provider in Ohio, every hospital and physician are covered, who handles Medicaid, are covered by the Medicaid not shared savings, it could be shared savings, but episode-based payment model. And basically, Medicaid has selected those episodes that they want to make risk-bearing, and then they're going to expand over the next 3 years. They're going to add 18 new episodes that are risk-bearing. And I'm not going to go into it all now because it really deserves its own webinar, and we can talk to Medicaid about that also. But it is something you want to be aware of. If you do any Medicaid work, you are automatically participating in this, and you are automatically at risk. And Medicaid, consequently, is part of the all-payer Medicare model, has been accepted as one of those. So just, again, be aware of that.
And those episode-based reports are available now within the Medicaid, the MIPS system, MITS. If you've not seen these episode reports, log into MIPS or find who in your organization has that login. Get a copy of these reports and read them over.
Yeah, I think that right now, Medicaid had gone slow when they first started this program a couple of years ago, and they increased it in 2018. I think they're up to 9 episodes, but they're really taking off next year. But the reports are very good. I like Medicaid's reports, easy to understand, but you want to be reviewing it by episode. It's not an all or nothing proposition as far as being either receiving a bonus or a penalty. It is done by each and every episode, so you want to be aware of them. And some of them are ambulatory measures. They are not all hospital or surgical. And this is a reference guide that you can link to. We'll send you the actual copy of it that explains the reference, the episodes. I think it's quite helpful because it shows what the episodes are, whether it's attributed to the hospital or a physician, and what the quality metrics are around that. So again, be aware of this going into 2019 because it's going to be a very important area for you.
All right, Kathy, we do have a few questions. Give me a second to pull these up, make them a little larger for me to read here. And sorry, guys, give me 1 second. My keyboard's all right. We'll just make do. Patients are angry at the doctor that wants to charge for a 5-minute call. Will they also be charged for the doctor-to-doctor consult? I'm assuming they're meaning the copay. Do both doctors get to charge for the patient?
For the copay, it's my understanding that both doctors get to charge for the patient. And as far as the copay, I think anytime that a physician bills Medicare, there's going to be a copay unless it's like a preventive service or something where it's specifically ruled out. So yes, I mean, you're going to have to consider the strategy around the use of some of these new technology codes. But the reality is so much more of business and healthcare is done now through email that this is a way to adapt if you want your program to use emails to respond to patients.
And when we say email, we mean
HIPAA secure email, direct email.
Yeah, either direct or through your portal.
Yeah.
Okay. Somebody asked what EPCS stands for.
E-prescribing of controlled substances. And this is a term of art. So if you refer to all caps EPCS and you ask your vendor about it, they will know what you're talking about.
What public reporting registries are available in Ohio? As a practice reporting MIPS, what if my practice doesn't collect data in the categories that are available within Ohio? So in Ohio, we have immunization registry, syndromic surveillance. For the providers, we have cancer. For the hospitals, we have ELR.
Right.
And if you do not report under QPP for any of those, you've really got to look at the clinical registries and QCDRs and a few other options that are out there.
Yeah, CDC, I think, also is included in one of the public registries.
And some of the specialty societies will have what they consider a quote-unquote meaningful use approved registry.
So if you work with a specialist who is just not eligible and you're not doing group reporting that would cover the specialist within your normal public health reporting like immunization, Then you're going to have to consider, will they exclude out of all the Ohio reporting for public health reporting? And then you have to look at their specialty program. And if their specialty association is not involved in public health reporting, then you can exclude out of that.
Just to clarify, for promoting interoperability, is your understanding that you must have at least 1 point in all required areas?
You must, yes. CMS made very clear in the regs that you have to have 1 patient in each area. However, on the e-prescribe, that was the whole issue about the interpretation and how you interpret e-prescribe. CMS is saying that the 1 patient does not have to be a case of controlled substance e-prescribe. You can go ahead and just report whatever your numerator and denominator is for normal e-prescribing. For health information exchange, you would need to have 1 patient's information being pushed out in a transition of care and 1 that you've brought back in.
There is some exclusionary language for that,
right,
bringing the information in. And if it's like we've seen with past exclusionary language, it's kind of got to be a technology issue.
Correct. Correct. And patient access is 1 patient's information needs to be pushing to the portal. But let's face it, if you're only doing 1 patient in each area, if you are a hospital, you will not meet your minimum reporting requirement. If you are a physician, it obviously is going to lower your score considerably, but you obviously could do that. On the physician side, there is an exclusion for HIE for under 100. There is not one on the hospital side.
For the API, is there a threshold, like for a minimum number of patients that must use the API, or do you just need to have the capability?
Okay, this again, and this is why I'm waiting to see these information blocking rules. You're supposed, the way that the rule was originally written, you were supposed to have the capability, and your vendor had to be certified for a certain type of hookup, whether it's fire or something else. And the reality is you're supposed to have 1 patient using the API, but CMS has not clearly said that if you offer it and you don't have an active patient using it, whether you can attest. We will get clarification from CMS about this, but I was kind of holding off, waiting to see if the information blocking reg had any further information about this.
The question will also be, can your vendor tell? Can your vendor provide you a report that shows you how many patients are making use of the API? And the way I've seen the reports right now, they just kind of bucket that access into the
patient
portal.
Yeah.
So my recommendation would be find an employee of the organization who is also a patient and set them up with the API. So that way, at least you know you've got one and you can demonstrate that you have one.
Yeah, but we will let you know as soon as we get a response from CMS about whether you need to have 1 patient using the API or whether you can just document that you have made it accessible through information to the patient and through your vendor having those connections.
Last question, Ms. Cathy. Are all independent practice providers placed in MITS, I'm assuming that means the episode-based program, without even knowing it, and even if they didn't enroll in the Medicaid MU program?
Right. This is not MU, and it's not the Medicaid CPC. I just want to be sure everyone's clear. There's 3 different programs we work with on Medicaid. They continue on meaningful use until 2021. You have the Medicaid CPC, which, unless the legislature would defund it, will continue on indefinitely for primary physicians, additional funding. The episodes of care is totally unrelated to those 2. Episodes of care is determined strictly by claims. Every Medicaid provider is part of it, but the reality is 80% will exempt out. There you would see no change. In fact, if you weren't aware of it and it's already been in existence for close to 2 years, then the reality is you fall in that vast middle group. If 10% your cost is higher than those 80% or 90%, then you can have your payment cut back. If your cost is lower than 90%, then you can receive a bonus. And there is information at the Medicaid portal about how many providers have received either a bonus or a penalty for each one of those episodes.
That was our last question. Thank you so much for joining us for our Monday morning webinar.
Good luck on effort to everyone with this week. I hope your computer doesn't run like Scott's does.
Yeah, I think mine was possessed. We did record the webinar. I'll get the recording cleaned up a little bit. We'll get it uploaded. Give me until, we'll say, the end of the week, and I should have it up on the CliniSync YouTube channel.
Thanks all. Have a good week.